Today, I will be speaking on sensorineural hearing loss, causes and management. I think we all know that what hearing loss means. So I will directly go to what sensorineural hearing loss means. I will show you what I try to explain to my patients. That hearing loss is actually of two types, the conductive hearing loss and the sensorineural hearing loss. It is quite easy to make them understand by showing this picture where you have a light bulb, and this is the circuit by which the light bulb works. There is a switch and there is a main supply and there are wires. So if you put on the switch and the light bulb still does not glow, there can be problems at different levels of this circuit. There can be a problem in the light bulb itself. The light bulb, the filament may be broken. There can be another 1,000 problems in the light bulb. Now this is what is we called the conductive hearing loss. That is, the problem is in the external ear or the middle ear only. But there is a large part of the circuit which is behind the light bulb, and in case of hidden circuits, we don't know the wiring of the bulb. And in this wiring, there can be problems. There can be a problem with the switch. There can be a problem with the wires here. And all this makes up what we call sensorineural hearing loss. There can be a problem with the holder. So we can say that here the holder of the bulb is the cochlea and the auditory nerve is the wire. So you can have different problems in all these parts. The holder, that is the cochlea, or the auditory nerve, which is neural. So sensorineural hearing loss. So this is what I try to explain to my patients, and I hope it will be helpful for you also. Whenever we talk about sensorineural hearing loss, the first thing which comes to our mind is age-related sensorineural hearing loss. It is also called age-associated sensorineural hearing loss. Now remember, age-associated and age-related sensorineural hearing loss are used interchangeably and synonymously. So both are synonymous and you can use any of the two nomenclature. Now what are the features of age-related sensorineural hearing loss? It has to be progressive. It has to be bilateral. So progressive and bilateral sensorineural hearing loss you can stamp as age-related sensorineural hearing loss. Just a minute. I'm sorry. Now, since we are saying that it is age-related, there has to be an age criteria for it. Well, it is mid to late adult onset. There has been no consensus about what is the age after which we can say that it is an age-related or age-associated sensorineural hearing loss. Some people will say that after the second decade, that is after the age of 20, all people will start to have some form of hearing loss. So you cannot brand a 30-year-old person as an age-related sensorineural hearing loss patient. So that is why the progressive bilateral sensorineural hearing loss, which is occurring in mid to late adult onset, in mid to late age, that is called age-related sensorineural hearing loss. You have to exclude other causes. There are 1,000 different causes for sensorineural hearing loss. We all know there can be intrinsic factors in the ear. There can be extrinsic factors like loud noise exposure, ototoxic drugs, and different types of trauma to the head. There can be some systemic diseases, and there can be some diseases of the ear also, which can cause sensorineural hearing loss. Only after excluding all these, you can say that the patient is suffering from age-related sensorineural hearing loss. As I told you, there is no set age limit, but 50 has been decided arbitrarily that after the age of 50, a progressive bilateral sensorineural hearing loss where no other cause can be plausible or can be found out after thorough investigation, we can stamp that as age-related or age-associated sensorineural hearing loss. typically after investigation, that is after doing a audiogram, you can find that the hearing loss is mainly in the higher frequencies. So it's a high frequency loss. Low frequencies are spared till very late in the progress of the disease. Now, previously there was a term called presbyacusis, which came from the term presbyacuse. And this presbyacuse was specifically for the high frequency hearing loss, which was diagnosed by Sir Francis Galton, who had a number of tuned whistles, and he used to use those tuned whistles to diagnose hearing loss in patients. And that high frequency hearing loss was specifically termed as presbyacusis. It has now been superseded by the terms age-related or age-associated sensorineural hearing loss. There are a few histological subtypes of age-related hearing loss. Though we know that the management of all age-related hearing loss zeroes down to only one thing, and we know what that is. I will tell you later on. But we have to think about the histological subtypes, because some of these histological subtypes may have different types of presentation and different types of audiograms, by which you can understand the pathophysiology. I'm sorry, someone says that I'm not audible. Am I audible? Hello?
No, sir, you are audible. You can continue
Okay.
the session.
Okay. Dr. Mrudula has said that she's not. I am not audible. So
No.
please check your connection. Please check your connection. Okay. Thank you. So at one end of the spectrum is sensory. The sensory type or the histological type will be where there is loss of hair cells. We know there are two main types of hair cells, the outer hair cells and the inner hair cells, and there are also supporting cells and some sustentacular cells, and they occur mainly at the basal end of the organ of Corti, and that is why we have the high frequency hearing loss. Now it starts at the basal end, but gradually the loss progresses towards the apical end. So even if it starts at very high frequency, it will eventually also cover the low frequencies, but it is very late generally in the course of the disease. Other than sensory, there can be a neural subtype. What neural subtype? Where the cochlear hair cells will be spared relatively, but there will be degeneration of cochlear nerve neurons. So if you cut the cochlear nerve and you find that most of the neurons are dead, and there will be cochlear ganglion cell loss. So this is the neural subtype. You can have further vascular or metabolic type. Now, it is controversial whether to call this vascular or metabolic type to be age related, because we are already saying that there is a vascular or metabolic etiology to it. But since it is found only in patients who are aged more than 50, and it occurs in a progressive bilateral fashion in both the years after the age of 50, say, or in mid to late adult onset, this is also a part of the age-related hearing loss. And what happens here? The stria vascularis, as we know, that it is a very vascular structure in the cochlea, and there is atrophy of the stria vascularis. And there will be loss of strial tissue in the cochlea, mainly in the apical and the middle turn. So here the loss of hearing will be more towards the lower frequencies. That is why this vascular or metabolic subtype may sometimes have a different type of audiogram where more low frequencies will be affected. A fourth subtype is mechanical or cochlear conductive, that due to, as we all know, that whatever organ we use or whatever instrument we use, after a few uses there is wear and tear of the instrument. The instrument loses its sharpness, loses its elasticity, loses its plasticity, and gradually the instrument loses its use for which it was bought or it was used. Similarly, the cochlear basilar membrane, it after working for all its life, it becomes stiffened and there is loss of plasticity of the cochlear basilar membrane, and there is increase in the number of fibrillar layers of the basilar membrane. So it becomes fat. We know that the basilar membrane movement is what actually gives rise to the sensation of hearing, because the organ of Corti will be excited, the hair cells in the organ of Corti will be excited only when there is movement of the basilar membrane in a definite fashion. Now, due to increase in the number of fibrillar layers and stiffening of the basilar membrane, there can be a mechanical or cochlear conductive hearing loss. And this type of hearing loss will have a flat audiogram, because however much you try to raise your frequencies or raise the loudness, the cochlear basilar membrane will not be able to vibrate or it will not be able to move. So this is again another type of age related sensorineural hearing loss where you can have a flat audiogram. So we have known that in the sensory and neural we will have a high frequency type of hearing loss, a vascular or metabolic where we can have a low frequency hearing loss or mid frequency hearing loss, and mechanical or cochlear conductive where you can have a flat audiogram. Now there is an intermediate subtype. As we all know that these histological subtypes, they have been done by experimenting on the cochlea of dead persons mostly, and in the cochlea of different animals. So that is why there were some subtypes which could not be categorized into the four of these. So one of these is intermediate, where you can have a bit of sensory, a bit of neural, a bit of vascular, a bit of mechanical. So what happens here is there is submicroscopic changes of the cochlear duct. There are changes in the intracellular organelles which are involved in cell metabolism. There is decrease in the synapse number. This is also called synaptopathy. That is the neural component, the cochlear ganglions are okay. The cochlear nerve neurons are all right. But in the ganglions at the nerve junctions, there is some problem. There is loss of neurotransmitters, mostly the glutamate neurotransmitters. And this is how the intermediate subtype will come. And there is maybe changes in the endolymph composition, and this is also maybe due to changes in the stria vascularis. That is what I told you, that everything with age stops functioning or decreases its function. So intermediate subtype will be a combination of all of these. And there is a further subtype which is mixed, where you can have features of all of the above along with those of the intermediate type. So these are the 6 basic histological subtypes of age-related hearing loss. These are still experimental, and why these experiments were done? To find out cure for age-related sensorineural hearing loss. As we all know that there is not much cure for age-related sensorineural hearing loss. At best, we can provide some sort of help to the patients to amplify the sound which is coming from outside, but the function of the cochlea or the function of the nerves, they cannot be regained much. But we are trying to understand the pathophysiology behind the loss of function of cochlea and auditory nerve, so that we can try to regenerate the specific place where the loss has occurred. So this is what I was telling you, that electron microscopic pictures will show you that there is a loss. Okay, somebody says that the audio connection is not stable. I hope I am audible to everybody. Okay, so what I was telling you, that there are inner hair cells and outer hair cells, and in the lower picture, the outer hair cells, they are mostly gone. You can see there is loss of outer hair cells, and after the loss of outer hair cells, the inner hair cells will also go in succession. So this occurs in age related sensorineural hearing loss. There is gradual death, necrosis, apoptosis, as well as death of the outer hair cells. And this is what leads to the sensory hearing loss. Other than age, the other factor which is very important in causing sensory loss is texture. I have given this picture to show you that what is the normal level of sound which we found in our ambience or in our environment. And you can see that the clock is pointing towards 80 decibel. Why? Because somewhere near 80, it is 86 decibels or something, which is considered to be safe for the ear. And anything above this is considered to be unsafe at different periods of exposure. So see, rustling of leaves, it is very 20 decibel, and a faint whisper may be somewhere around 30 decibel. We know that our speech frequencies, the speech will be about 40 to 50 decibels, and we can have different types of noise exposure at different places. And we see one of the highest exposures to noise is the jet engine at takeoff, the aeroplane takeoff. And gunfire and space rocket, these are only for very trained individuals. So this is some kind of exposure which we have to limit to save our hearing. That is why I wanted to show you this picture. So loud noise exposure is another cause of sensorineural hearing loss. We know that there are two types of sensorineural hearing loss which occur due to loud noise exposure. One is the temporary threshold shift, and the other is the permanent threshold shift. So there is a shift in the threshold of hearing, and it can be temporary, it can be permanent. So as I told you that less than 80 decibel absolute hearing level, it is unlikely to cause hearing damage no matter how long you are exposed to it. But 130 decibel or greater, it will damage your hearing even if you are exposed to it for a very short period. As I told you that the jet engine takeoff or the gunfire or the rocket takeoff, if you are momentarily also exposed to that sound without adequate protection of hearing, then you are liable to be to have some type of hearing loss, sensory hearing loss. Now, the essential pathophysiology behind the temporary threshold shift is metabolic. There is changes in the endolymph and the perilymph and the cortilymph, and that is why these occur. But in case of a permanent threshold shift, the changes are structural. That is why they become permanent. If you change the structure of the organ of Corti, if you remove a few hair cells, if you change the shape or the plasticity of the say cochlear membrane, the basilar membrane, you cannot revert that back. Metabolic changes you can revert back because it is just about diffusion of a few ions of some minerals. So metabolic changes, they return back to normal after the loud noise is stopped. But in case of structural changes where there is permanent threshold shift, it does not revert back to normal. So what is the type of audiogram you will get? It will be a high tone hearing loss, that is a high frequency hearing loss, and there will be a notch at 4 kilohertz or 6 kilohertz. Typically at 4 kilohertz we get a notch, and there is some recovery at 8 kilohertz. So if we get an audiogram like that where it is sloping down and then it is rising again at 8 kilohertz, you can safely say that this is a noise induced hearing loss. And as which is important to remember that significant hearing loss below 2000 kilohertz, 2 kilohertz is extremely uncommon in noise induced hearing loss. So this is the type of audiogram which you get. See, the one of the ears, the left ear, is almost normal, but the right ear, which was exposed to a loud sound, it shows a dip at 4 kilohertz, and there is again a recovery up to 8 kilohertz. So this is the type of audiogram where you can safely say that it is a noise induced hearing loss. Now, how much noise and for how long will cause how much damage? It is a very pertinent question. Why? Because it has medico-legal aspects. Suppose there is a worker in a factory who is exposed to loud sounds for a very long time, and then after some years he develops sensorineural hearing loss. So is the employer liable for providing damages to the employee, or should the employer be responsible for giving protection to the ears? Now that is why these formulations have been done. Burns and Robinson, they gave a noise emission level. Noise emission level is LEPD plus 10 log 10 T, where LEPD is the noise level, average noise level, and T is the time period for which it was exposed to. So it is a addition of the noise level and a 10 times log 10 of the time for which it was exposed to. And there is also the equal energy principle, that suppose you are giving a person 85 decibels for 8 hours, the damage it will do is equal to 106 decibels for only 3 minutes 45 seconds. So if you increase the noise level, the time period for which it may be given to the ear without permanent damage becomes less. So this is because of this equation. So you have to find from this equation that how much sound level will produce only very low noise frequency, noise induced hearing loss in how much time. So that is the time period for which the employees can be exposed to that sound for the maximum period. Otherwise, either you have to give protection to the person, or you have to ensure that his hearing is taken care of by other means. So this is something very important. As I told you that in temporary threshold shift, there occurs some problems in the structure of the cochlea. What there occurs depolymerization of actin filaments in the stereocilia, that is the hair cells. We know that stereocilia in the hair cells, there is the kinocilium and the stereocilium. The kinocilium is the longest hair cell and the stereocilia are the rest. And there is depolymerization of the actin filament. So there is loss of plasticity. The movement of the stereocilia will be hampered, and there can be changes to the non-sensory elements of the cochlea, such as swelling of the stria vascularis and afferent nerve endings. There can be apoptosis and necrosis of outer hair cells due to prolonged exposure to loud sounds or due to exposure to very loud sounds. And these apoptosis and necrosis is mediated by certain enzymes or the caspases. We know cysteine aspartate transpartases. So these are the enzymes which actually cause the sensorineural hearing loss in a lot of procedures. Like later on, I will show you in different slides that even in ototoxic drugs, these caspases are the culprits. Now, why this is important? We have known this, and by doing this, we have found that caspase receptor blockers, they can block the effects of ototoxic drugs, as well as they can block the effects of loud sound on the outer hair cells. So this is something which is important, and it's an area of ongoing research where we can find an answer to sensorineural hearing loss by different agents. Synaptopathy is something where there is problem in the cochlear nerve synapses or the cochlear nerve junctions. And in these patients who are suffering from synaptopathy, you can have a hidden hearing loss. The audiogram may not give you much insight into it. The audiogram may be normal or near normal, but the patient will still have hidden hearing loss. Why? Because the hair cells are functioning perfectly well, but there is problem in the synapses of the cochlear neurons. The cochlear neurons are also good, but if the problem is in the synapses, they will not be picked up by very reliably by the audiogram, and the patient will have difficulty in understanding specific words. This is called synaptopathy, and it gives rise to hidden hearing loss. Now, there are predisposing factors to noise-induced hearing loss. Not everybody who is exposed to loud sounds will be having the noise induced hearing loss, but only some of them will have. Why? Because they may have some genetic predisposition. It can be associated with a age-related hearing loss. If you burst a cracker in front of a ear of a 80-year-old person, he will instantly have some kind of hearing loss, and you will not be able to differentiate whether it is due to age-related hearing loss or it is due to the noise-induced hearing loss. And smoking, diabetes, hypertension, and blue eye color. This is very important. This blue eye color persons are more susceptible to noise-induced hearing loss. Well, the symptoms are not always only hearing loss, and the more disabling symptoms of noise-induced hearing loss are actually tinnitus and hyperacusis. And you know that just after Diwali, we get a lot of patients who come to us mainly with the complaints of tinnitus and hyperacusis. And even if you ask them a lot of times that whether they are hearing less, they will not be able to tell you, because they are not actually concerned about the loss of hearing at that moment of time. They are more concerned about the hyperacusis or tinnitus. That is, some sounds will actually startle them, and the tinnitus will disable them. So this is something which has to be remembered. And as I told you, there are medical legal aspects of noise induced hearing loss which we have to remember, because many a times you can have you have to go to the court to testify whether employee is liable for damages from his employer for the noise induced hearing loss he has occurred which has occurred during his occupation. Now there is something called acoustic shock. We know that we generally call the noise induced hearing loss as acoustic trauma, but acoustic shock is something which is different from acoustic trauma or noise induced hearing loss. It is actually not pertaining to the hearing loss itself. It is pertaining to the psychological aspect of the sudden increase in size or increase in noise. It may be due to sudden increase in noise, or it may be due to a prolonged exposure to a noise which the person is not liking. So it is actually a type of acute stress reaction. It can be called an excessive startle response or a type of post-traumatic stress disorder. And it has been found that the myoclonic activity of tensor tympani is the culprit here. And that is why the presenting symptoms of acoustic shock are generally hyperacusis, otalgia, tinnitus. And see, hearing loss is lying at the bottom of the table. It is only about 20% who present with hearing loss. So the main problem with acoustic shock is hyperacusis. And this is mainly related to something unpleasant which has been heard by a call center employee. So this is very, very common in these days, because we have a lot of call center employees who are on the phone or using the headphone for a long time, and they have to speak to a number of persons of different types. They have to speak to their seniors, they have to speak to their juniors, they have to speak to different clients, and somebody, maybe somebody who is superior to them or somebody who is a client, has said something which causes acoustic shock, and the patient will suffer from different types of mostly psychological reactions. So this is something which has to be treated very, very sympathetically and very emotionally rather than medically. So what is the management or prevention of noise-induced hearing loss? Well, earplugs, they are very important, and they give 10 to 15 decibel of sound attenuation. But ear muffs are always better than earplugs, and at least 15 decibel of sound attenuation is given by the ear muffs. You can give active noise reduction. It is expensive, and active noise reduction, they are also delivered through ear muffs, but it is very expensive to give to all of the employees. So ear muffs and ear plugs may be adequate. And for acoustic shock, not much treatment, but psychological counseling is the treatment, and probably the counseling to leave the job and to take up another job. That is for acoustic shock. Now we will go to other different types of sensorineural hearing loss. There are some intrinsic otological diseases which can also lead to sensorineural hearing loss. We have to be very wary of them, because whenever we think of sensorineural hearing loss, we think that the ear probably is normal. It may not be normal. You can have otosclerosis where along with the conductive deafness, you can have some amount of sensorineural deafness. We all know that there is a condition called cochlear otosclerosis which can give rise to sensorineural hearing loss, where there is spongy bone formation on the cochlear bone also. Well, Meniere's disease, this is very important in the pathophysiology of sensorineural hearing loss, and repeated attacks of Meniere's disease, acute Meniere's disease, will lead to sensorineural hearing loss. Chronic otitis media and as well as acute otitis media. We all know that there is the round window which is guarded by the round window membrane. But the round window membrane is not opaque to different toxins, and it is semi-permeable. So there are different bacterial toxins as well as endogenous toxins of the body which can get transported through the round window membrane into the cochlea. And this is what occurs in case of chronic otitis media. We have seen patients who are suffering from chronic otitis media, and they have been using different types of ear drops, mainly aminoglycoside ear drops, for a long time, and they later on come to us with sensorineural hearing loss. So one of the mechanisms of this sensorineural hearing loss will be the transport of the aminoglycoside antibiotics through the round window membrane into the cochlea. So chronic otitis media as well as in acute otitis media, as I told you, some bacterial endotoxins, they can go to the cochlea through the round window membrane. Well, ototoxic drugs, these are very important to know about sensorineural hearing loss. We know aminoglycoside antibiotics, they are the most notorious culprits in the ototoxic group of drugs, and amikacin of them is very dangerous. Gentamicin, which is generally used for UTI as well as there's urinary tract infection as well as meningitis. Streptomycin, which is a very potent drug for tuberculosis. Tobramycin, kanamycin, which we use for different types of infection, mostly the gram-negative infections. These are all implicated to be ototoxic. Macrolide antibiotics, erythromycin is very important because erythromycin is sometimes given for patients who are resistant to penicillin or who are allergic to penicillin. Erythromycin is the most abused drug in India at the moment. Clarithromycin is also given for patients who are not responding to the first line of antibiotics. Other antibiotics, now see, even ampicillin, which is a very benign type of antibiotic, even it can cause some kind of ototoxicity. Anti-tumor agent cisplatin is the most notorious of them. Anti-inflammatory agents, all anti-inflammatory agents are ototoxic. Remember this. Other, well, probably with the exception of paracetamol, all are ototoxic drugs. And for a patient who is suffering from hearing loss, you have to be very careful about giving analgesics. Anti-malarials, quinine and chloroquine, they are very old culprits, and they have been known to cause hearing loss for a very long time. Loop diuretics, we all know that ethacrinic acid, being the most potent loop diuretic, is never used because of its ototoxicity, and we use furosemide, but furosemide is also ototoxic. But thankfully, most of the ototoxicity of these drugs is reversible. Iron chelators like dysferoxamine, even beta blockers, contraceptives, and most importantly, industrial chemicals. We know that industrial solvents, and there are these industrial solvents are found in many daily use items like adhesives or gums, and we know that there are adhesive abusers. Some patients who inhale the fumes of adhesives or inhale the fumes of petrol or gasoline, and these fumes and adhesives, they contain toluene, and this toluene causes ototoxicity. It was found in an experiment where the adhesive abusers were found to have hearing loss, and it was found to be due to the toluene exposure. Okay, there are different pathways or pathophysiologies by which ototoxic drugs exert their effects. And there are different types of pathophysiologies. The most important of them is the loss of hair cells, the outer hair cells. Most of the aminoglycoside antibiotics, they cause apoptosis or necrosis of the outer hair cells. Even cisplatin does that. Even the aspirin group of anti-inflammatory agents and antimalarials. There are some agents like the loop diuretics which exert their effects at the stria vascularis. There is first there is swelling of the stria vascularis, there is involvement of the stria vascularis, and later on, after a long time use of furosemide or loop diuretics, there is drying of the stria vascularis and it becomes thin. So there are different pathways by which ototoxic drugs exert their ototoxic effects. Some have specific vestibulotoxic properties, but most of them cause equal damage to the vestibule as well as to the cochlea. But as I told you, most of these agents, when stopped, the ototoxicity will go away. Only in a few cases it is permanent. And kanamycin is very notorious for doing a permanent ototoxicity, where even if you stop kanamycin, the hearing does not improve. The rest generally they improve, and you have to be very wary of this, because the if you can correctly recognize that when the ototoxicity is occurring, you can stop that drug and you can bring back the hearing. Probably the first sign of ototoxicity will be a disabling tinnitus and some amount of vertigo. So whenever a patient who is receiving an ototoxic drug for some condition is suffering from tinnitus, be very cautious and get an audiogram done, and then you stop that offending agent. Now, there are different medical conditions which can cause ototoxicity. How? Mainly by restricting blood flow to the cochlea. The cochlea needs a lot of blood flow and oxygen, and we all know that atherosclerosis occurs in arteries and it can cause restriction of blood flow. Hypertension similarly can cause restriction of blood flow. Diabetes mellitus, the same thing, it can cause sclerosis of the arteries and cause limitation of blood flow. Paget's disease of bone also causes limitation of blood flow. Similarly does myxedema by increasing the connective tissue layer inside the blood vessels. So all of these conditions can also cause restriction of blood flow to the cochlea, and hence it can lead to cochlear hair cell loss, cochlear neuron loss, and auditory nerve loss, and so it can cause sensorineural hearing loss. So whenever we are dealing with a patient of age-related hearing loss, the age-related the overage person will also suffer from all of these conditions like atherosclerosis, hypertension, diabetes mellitus. So we have to be very cautious whether these are also contributing to his age-related hearing loss or not. So a patient comes to you with hearing loss. You guess that it's a sensorineural hearing loss by doing the tuning fork test. So what are the investigations you are going to do? As I told you, it is very difficult to explain to the patient that why we are getting an investigation done. For that, you have to go to that picture on the first slide of my presentation, that the light bulb is not working, but now I have to find out whether the light bulb itself is defective or there is some problem in the wiring or the switch or in the main supply. That is why the audiogram is required, to find out the exact point of problem in your hearing. So in a pure tone audiogram, you can get a high frequency hearing loss. And next you can go do some radiological investigations. The most important of them is a magnetic resonance imaging of the brain. When do you do the MRI? You can do MRI only when there is a difference of more than 10 decibels averaged over the speech frequencies, or there is a difference of more than 20 decibels at any single frequency. And in case of unilateral tinnitus. Why? Because other than age-related sensorineural hearing loss, you can have other pathologies, mostly in the brain, like acoustic neuroma or some other pathology in the acoustic nerve or in the, say, midbrain. So these are the clear indications of MRI. in addition to the audiogram. So now I will come to the next part of my presentation, where how to manage a patient of sensorineural hearing loss. Well, there are two distinct stages of management. One is non-specific and the other is specific. Specific means treating the main pathology, that the person is hearing less, and non-specific is how to rehabilitate a person who is not hearing more. Here comes the very pertinent question, that a person who is aged and who does not do much work, he does not have to go out, he does not have to go for some occupation, he does not have to work, earn money, does he need to hear? Well, let me tell you that age-related hearing loss impacts psychological well-being as well as physical ability. Just because a person is not hearing, he may not be physically very strong. If a person does not hear well, he will be afraid to speak to other persons, he will not speak to other persons, and it will lead to something called social outcasting. And he will be afraid to go out, because whenever he can't hear, he will have a fear of different sounds, like he will have the fear of the honking of the vehicles, he will have the fear that the vehicle will probably hit me on the road, and this leads to social outcasting as well as physical physical imprisonment of the patient within the house, and this leads to a lot of psychological issues like depression, dementia, and gradually the patient will lose his physical ability of walking and he will have an increased incidence of falls. All of these have been proved in different studies which have thousands of patients enrolled in them. So this dilemma to treat or not to treat is actually skewed in favor of to treat. So whatever the age of your patient, whatever his condition, whether he is bedridden, whether he is bound to a wheelchair, whether he is just keeping in the house, he is not going out, you have to treat the hearing loss of the patient. How you treat it, that is what I will discuss in the next slides. First, you have to go for some non-specific management. A person comes to you and says that I can't hear, and probably I can't understand what I am hearing. I can hear, but I can't understand what I am hearing. You have to speak to him about optimization of acoustic environment. That see, you are a 80-year-old person or you are a 60-year-old person. You cannot hear in a disco. You cannot go to a disco, or you cannot hear well when you go to the market where a lot of people are talking simultaneously. So you have to optimize his acoustic environment. You have to talk to each person on a one-to-one basis and on a face-to-face basis. You have to try to read his lips. Even if you can't hear, lip reading will give you a lot of idea about what the other person is speaking. So this is also a type of psychological counseling of the patient. And you have to bring that patient from the denial of the problem to acceptance of the problem. All patients who are hearing less will come to you saying that I am not hearing less, but the other persons are speaking in a low voice. This is a very common problem, that all my family members, they speak in such low voices, that is I can't hear. Now you have to counsel them by to accept their problem, that it is actually their hearing which is hampering and not the voices of the other people which is faulty. You can give them different electronic gadgets and accessories. Suppose a person is watching television with the others of the family. Now if everybody can hear the sound at a certain level of the remote control, at a certain volume level, suppose at 15, the old person who is not hearing will have to keep it at 25. Now that will be noise to the others. So what you can do is, you can give some Bluetooth earphones to the old age person, and then he will hear in his own volume and the others will hear in their own volume. So these are these are different types by which you can do some non-specific management rather than going to the problem itself. So what is the specific management? The specific management is hearing aids. there is no denying of the fact that hearing aids are probably the best rehabilitation for a person who is hearing less due to some reason or other, whether maybe due to age, maybe due to loud sound exposure, maybe due to ototoxic drugs, permanent damage. Whatever the problem, if there is a sensorineural hearing loss, the best treatment for them is hearing aids. It improves their quality of life. But again, you have to counsel them to use their hearing aids to improve their quality of life. Now, what type of hearing aids will help them? We know that there are two types of hearing aids in the market, digital and analog. It is now firmly established that digital hearing aids are much more better than analogs, and analogs are out of the market. They are not available commercially these days. So digital hearing aids, what they do is they can amplify different sounds. They have some type of artificial intelligence where they can filter some sounds, and so it is not like our human ear, but it is somewhere about 50% like the human ear. Always remember that binaural hearing is always better than monaural hearing. Why? Because of the signal to noise advantage. A person who is fitted with a hearing aid on one ear will catch more noise than the voice he is wanting to hear. So these persons, when they go to a very noisy surrounding, or when they are hearing 2 or 3 people speaking together, they will be confused and they can't understand whose voice to hear. So these are the people whom you have to counsel, that you have to go for both sides hearing aid fitting. And auditory rehabilitation. There are different parts of auditory rehabilitation. I will show you. And this picture shows the different types of hearing aids which are used. Auditory rehabilitation. This is very important, that the ultimate goal is living well with a hearing loss. So what are they? One is hearing devices, and one of the hearing devices is hearing aids. The other hearing devices, as I told you, Bluetooth devices, remote controls, and like that. You have to go for counseling, psychological counseling. The patient has to forego the fear that whenever I am using a hearing aid, people will think that I am deaf. You have to counsel the patient out of this fear. The patient has to go for visual cues. The patient has to listen to the person by facing the person. Suppose he is talking to somebody, he has to face that person, he has to read his lips, he has to take some visual cues from what the person is trying to say. There has to be auditory training, the environmental modification, that the person has to be said that you don't go to noisy surroundings, you cannot go to a disco with a hearing aid. It is not very comfortable for you. And there are different communication strategies, like as I told you, one of them is the Bluetooth headphones and the Bluetooth mic and everything. And all of these will give roots to the tree called living well with hearing loss. Now, there is another entity which is sudden sensorineural hearing loss. The definition is hearing loss of 30 decibel or more over at least 3 contiguous audiometric frequencies that develops over 72 hours or less. Now, this develops over 72 hours or less. This has been done away with, because a person comes to you and says that last night there was a blast behind just beside my ear, and after that I am hearing less. And you get an audiogram now. Now, you don't know that whether the person was actually hearing well in that ear previously or not. The person will always tell you that he was hearing less, but there is no certainty that the person is correctly saying that he was not suffering from sensorineural hearing loss previously. So there are different levels of diagnosis. That is certain, very certain, and there can be doubtful, very doubtful. So just because you don't have a previous audiogram, based on one audiogram, you cannot say whether it developed over the previous 72 hours, or there is something else. There may be an ototoxicity along with the noise-induced hearing loss. There can be age-related hearing loss along with the sudden sensorineural hearing loss. Suppose a person, as I told you, above the age of 60, a blast can occur near his ear. So age-related hearing loss will compound with the sudden sensorineural hearing loss. So that is why this 72 hours or less, this part has been done away with, and a hearing loss of 30 decibel of more, or at least over 3 contiguous audiometric frequencies, and of sudden onset. This is called a sudden sensory neurosis. It has different pathophysiologies. It can be due to a viral infection. As we all know, it generally occurs after a viral upper respiratory infection. It can be vascular due to some compromise in the blood flow to the cochlea. It can be due to autoimmune diseases. It can occur in Meniere's disease. It can occur in acoustic neuroma also. And we have found that 30% of acoustic neuroma patients will suffer from a sudden drop in their hearing loss. And it can be due to intercochlear membrane rupture. That can be due to acoustic trauma, or it can occur spontaneously also. Now, 4 factors affect the recovery. Time since onset: the earlier the presentation, the better the prognosis. Over the age of 50, prognosis is worse. Vertigo is a very poor prognostic indicator, so is tinnitus. And an audiogram where there is a sloping curve, they have a poorer prognosis. That more the hearing loss, the more the frequency, the more the hearing loss. So these patients will tend not to recover. The rest of the patients may recover. Now remember that while you are trying to treat these patients, you have to tell your patients that 50% of cases have spontaneous recovery with no treatment. So you can take your chance. If you don't want to go for steroid therapy, you can take your chance. The improvement rate in the first 2 weeks may predict long-term outcome. Now, what is the optimum period for treatment? We always tell the patients that it is the 24 to 48 hours or 24 to 72 hours window after the hearing loss has occurred, that the best management, the best recovery may be got. But it is not. Within the first 3 weeks, early corticosteroid treatment will be associated with greatest hearing recovery. But after 4 to 6 weeks, there will be very minimal benefit. And oral prednisolone at 1 milligram per kg per day for 10 to 14 days. That is the ideal dose which is given. But you have to remember that they have revealed no evidence of benefit in many studies which have been done. The steroids do not have much effect over placebo in evidence-based medicine. But still we give, because that is the only chance we have of saving the person from getting a hearing aid. There is an alternative to systemic steroids. What is that? That is topical steroid or intratympanic steroid. It is not topical, it is intratympanic or local steroid. And it is done in case of refractory cases or persons who cannot be given steroids, suppose due to uncontrolled blood sugar, uncontrolled hypertension, or peptic ulcer disease, and different types of steroid pathies actually. So 10 to 24 milligram per ml of dexamethasone or 30 to 40 milligram per ml of Saumitra. These can be given. The dose varies from different persons. Some people say 1 dose is enough. Some people say 3 doses. Some people say 5 doses. There have been patients who have got about 20 doses of steroids. There is no consensus about the dose as well as the number of injections we require. Facilitator agents like histamine and hyaluronic acid, which help in delivery of the drug around the round window membrane. And it is generally done through a spinal needle on a syringe, and you can have different types of other delivery routes like the myringotomy with a gromate, with a microwick or catheter, hydrogel applications, as well as nanoparticles which are injected inside the ear. Hyperbaric oxygen therapy, this is very upcoming, and this has promising results because it increases the oxygen supply to the cochlear nerve cells and the cochlear, the auditory nerves. It has shown promise, but the efficacy is only 30%. Acyclovir, valacyclovir, and different types of other drugs which increase the blood flow in the cochlea, which decongest the cochlear blood vessels, and which increase the oxygen supply to the cochlea. They have shown some promise, but not much evidence supports them. And a person who has come to you, say after 4 to 6 weeks or after 1 year. So what is the salvage therapy? The salvage therapy is actually a combination of all these, and you have to tell the patient that there is no guarantee for cure. A very important part of sensorineural hearing loss is the pediatric sensorineural hearing loss. We started from just like the film, the curious case of Benjamin Button. We started from the old age, and now we are coming to the child. And we know that there are 2 types of sensorineural hearing loss in pediatric age group, the prelingual and the postlingual, that is before and after the development of language, and there can be congenital and acquired causes. I will not go into the details, just that it can be syndromic, it can be non-syndromic, and it can have different types of genetic predisposition, and there can be non-genetic factors, and most of them are maternal infections or congenital infections, maternal drug abuse, maternal drugs which have been given for different diseases, mostly aminoglycoside drugs, which have gone to the child, to the fetus, and damaged his cochlea. There are different acquired disorders which are the same as the adult age group, and mostly meningitis. Different types of meningitis, they cause different types of cochlear problems. They cause cochlear ossification, and they cause infection in the cochlea. I will not go into the details, but the crux of management in pediatric SNHL is the early diagnosis. How? By newborn hearing screening. And we know that universal newborn hearing screening is already in action in India, and different agencies are trying to bring the newborn hearing screening to 100%, and autoacoustic emissions have to be done very quickly, and mostly in cases of NICU graduates. A child who has spent more than 48 hours in a NICU will have more chances of auditory neuropathy and auditory problems, and they have to undergo the OE. And in case of refer OE, we have to go for a ABR, or a auditory brainstem response. Hearing aids, different types of hearing aids, bone anchored hearing aids can be given in very small children when they are being still planned for cochlear implants. But the ultimate goal will be to implant the child with a cochlear implant at a very young age. Previously, the cutoff mark was 5 years. Now it has come down to 2 years, and it may come down to 1 year. So our goal is to implant all children with cochlear implant, all children with hearing loss, with permanent bilateral hearing loss, with cochlear implants below the age of 1, because then the results are the best. Probably they will not require any type of oral rehabilitation later on. Now I'll show you some specific types of audiograms. This is called the specific cookie type audiogram, where there is a sloping curve in the mid frequencies, and then again there is a recovery, and this is found in tecta mutation. It's a genetic mutation. Low frequency hearing loss. This is a curious type of audiogram. It is found very rarely, but it is found in WFS1 gene mutation, and you can find it in Meniere's disease, renal failure, cochlear malformation, a few viral infections, and fistula causing pressure changes. So these are very, very rare, but you have to know these mainly for quiz purposes, but once in a lifetime you will find a patient with this type of audiogram. Ski slope audiogram, it is found in a different type of mutation, OSBLP2, BPL2. And here also there will be a very steep sloping curve, and it will show some recovery at 8 kilohertz. So this is a ski slope audiogram. This is how we understand the audiogram. If you can see that there is a speech banana, and in the speech banana you can see different letters are written. Why I have shown this picture is, many patients with sensorineural hearing loss will come to you and say that, doctor, I can hear, but I cannot understand specific words. I cannot understand some specific words. Sometimes the people will tell you that I cannot understand cha and sha. I cannot understand ma and na. I cannot understand u and z, like this. This is because at different frequencies, these words are spoken, or these letters are spoken, or these sounds are spoken, and they have a different levels in the audiogram. So somebody who is having a hearing loss here will only have a deficiency of U and P, but the rest will be preserved. But somebody who is having here will have a problem with sh, but not with ch. So this is why I was showing you. So this is just for remembering that a person who is suffering from hearing loss will also suffer from poor discrimination of words, or poor speech discrimination score. That is why we do the word discrimination score or the speech discrimination score. So I think I have covered most of what I had thought I would cover. Thank you, and I am open to any questions. Well, there is one question from Vijay Rawat. Why is there dip in 4 kilohertz in noise induced hearing loss, and why there is hyperacusis? It's a very good question, I would like to tell you. Uh, the, the cause is very interesting. When there is noise induced hearing loss, I told you that there is a specific damage to the cochlear basilar membrane, and this cochlear basilar membrane loss is most prominent at 4 kilohertz. That is why there is the dip in at 4 kilohertz. But as I told you, that in all noise induced hearing loss, you will not get this dip. It is not universal. Why? Because you cannot say that it is only due to the damage to the cochlear basilar membrane always. There is also some hearing hair cell loss. There is also some metabolic derangements. So that is why this is not universal, but probably the cause is due to the change in the plasticity or the malleability of the basilar membrane, that the dip occurs at 4 kilohertz. And the hyperacusis is also due to loss of the cochlear function. As we all know, the cochlea has the function of regulating sound, and the hyperacusis is mostly due to the loss in the cochlear function, as well as due to myoclonus of the tensor tympani muscle, because the tensor tympani muscle will be hyperactive and there will be involuntary movements of the tensor tympani muscle. There will be hyperacusis. So it is a bit of, and there are also reports where they say that there is myoclonus of the stapedius muscle also. So the stapedius muscle, which guards us from high sound, from high level sounds or very loud sounds, they also can have myoclonus. So that may also be a cause of hyperacusis. Mrudula asks, any role of beta histamine tablet? No. There is no role of beta histamine tablet. Well, synaptopathy is a part of the spectrum of auditory nerve spectrum disorder or auditory neuropathy spectrum disorder. Tinnitus is not a good prognostic indicator of SSNHL. It is a bad prognostic indicator of SSNHL, because if the patient is coming with tinnitus, no, it doesn't mean the hair cells are intact. It doesn't mean, no. Well, diabetic Tripti Mondal says diabetic sudden sensorineural hearing loss. As I told you, that because he is diabetic, you probably cannot expose the patient to systemic steroids, corticosteroids. So you can go for intratympanic corticosteroids. And as I told you, you have to tell the patient that 50% of the patients recover without any treatment. So you can wait. And if you don't want to wait, then you can go for intratympanic steroids. There is no criteria for prescribing hearing aids. You have to talk to the patient. You have to optimize his hearing environment. You have to optimize his oral rehabilitation. And after counseling, if the patient is happy to take the hearing aid and use it, as you say, only then you can give the hearing aids. So there is no particular criteria. You can give the hearing aid for a mild hearing loss also. And some patients, even with very profound hearing loss, will not be very keen to take the hearing aids. So first you have to counsel, and you have to bring the patient from the denial mode to the acceptance mode. Only then you can give the hearing aids. So the main thing is counsel. There is no specific criteria, set criteria. In mild SNHL, the same treatment, in all SNHL, you can give the same treatment. In old patient, if you think that systemic corticosteroids are not indicated, I think you are speaking about, you are asking about sudden sensorineural hearing loss, Dr. Kamini. Sudden sensorineural hearing loss, you can give intratympanic steroids because they are less harmful to the patient. They are not given systemically. And if it is not sudden sensorineural hearing loss, you can go for a hearing aid, or you can, as I told you, you can go for oral rehabilitation. You can ask the patient to always talk face to face with the patient, with different persons, not to go to noisy areas, to use protection in the ears, because even in mild SNHL, he can have some amount of hyperacusis. So it is very common for us to get patients who say, they will say that, why are you speaking so slowly? I mean, so in such a low voice. And whenever you shout, they will say, don't shout. That is a sudden sensorineural hearing loss. And when you raise your voice, there is hyperacusis because of the myoclonus of the muscles. So these patients will have both the problems. So that is why it is very difficult to counsel them. But that is what we are being trained to do. There is no role of vitamin B12 in prophylaxis of SNHL or tinnitus. There is no such evidence, and I don't think it is recommended. First symptom and sign of SNHL, well, it is hearing loss, but the way the person presents the hearing loss is very different in different persons. Some patients will come to you saying, I am hearing less, but most of the patients will say and tell you, I am not hearing less, but they are speaking in a low voice. That some people will come to you with different types of depression, dementia, and like that, and they will say, most of the persons come to you with low speech discrimination. They will say that I am not hearing less, but what I am hearing I cannot understand. So I want to understand. So that is probably the first symptom of hearing loss. That is loss of speech discrimination. There is no role of methylcobalamin, as I told you. How to choose a particular hearing aid? Well, you have to go for digital hearing aids. You have to go for bilateral hearing aids. And you have to use different hearing aids on the patient. You have to go for a hearing aid trial. The hearing aid trial is very important. It is a part of the auditory rehabilitation. You have to go for different hearing aids, and only the hearing aid which is very comfortable to the patient and the patient is hearing better with that hearing aid, you go for that. In acoustic shock, does a specific word or words in general causes? Yes. It's a specific word or words or specific sentences or specific talk by a specific person that causes the stress. It is not a problem of stapedial reflex. It is mostly psychological. So I think there are no more questions. Conducting hearing loss suddenly. Conductive hearing loss, sudden conductive hearing loss. This occurs in case of trauma only. You can have a sudden conductive hearing loss in case of trauma where there is a rupture of the tympanic membrane, or in very intense trauma you can have probably ossicular discontinuity also, but it is very rare. Mostly the perforation of the tympanic membrane occurs due to a sudden trauma. And even then the hearing loss is somewhere between 25 to 30 decibels, sometimes say 30 to 40, 35 decibels. So the patient will generally not come to you with the hearing loss problem. Auditory neuropathy, PTA findings. Now see, auditory neuropathy we are speaking of in case of very small children. We don't do audiometry in these cases. We do a OAE. What will happen is in OAE, it will be pass. But in BERA or auditory brainstem response, you will find it is deranged. The wave 5 will not be formed properly. So this is what is auditory neuropathy. That is why auditory neuropathy is difficult to diagnose, because even if with a pass OAE, you can have a defective BERA. PTA findings, no, there are no PTA findings in auditory neuropathy. Conductive hearing loss, Dr. Kamini, do you want to know about traumatic tympanic membrane rupture? We don't give any medicines. We wait for 6 weeks, and I think more than 95% patients recover with no treatment at all in case of a traumatic rupture of the tympanic membrane. Just ask the patient not to fiddle with the ear apply no drops, and do not scratch the ear, do not use any picks or something, and it will. Well, some people will do everything. Some people patch. But it's not. You can think you can give like the teeth. Well, aminoglycosides have different mechanisms of action. The most prominent of them is apoptosis and necrosis of outer hair cells. And all aminoglycosides cause some amount of apoptosis of outer hair cells. Some are more, some are less. Uh, the answer will be yes. All aminoglycosides cause apoptosis of outer hair cells, but there is some amount of disparity between which causes more ototoxicity, some causes less ototoxicity. Hearing dogs is part of the auditory rehabilitation. That is for the protection of the elderly who are not hearing. Now uh, you know that there are there are two specific days. One is the World Hearing Day, which is on 3rd of March, and there is a World Deaf Day, which is on the last Sunday of September. Now, World Deaf Day is not for the ENT surgeons. The World Deaf Day is for the International Week of the Deaf. So that is where the deaf celebrate their deafness. The deaf, they don't want to hear, they don't want to be like us. Now, for these patients, somebody who is not wanting to hear or somebody who cannot hear probably, uh, because you will find some patients who are not benefiting from hearing aids also. So, how will you alert these patients to danger, to fire, to different vehicles on the road, to different, and how do you give this patient a companion? If you can't give a human companion, you give them a dog, a hearing dog. So, that is what about hearing dogs. Uh, a patient with hyperacusis will be able to tolerate PTA. It is not that they will not be able to tolerate PTA. They will have some hyperacusis, and you have to go for different, you have to go for a Puton audiometry first, and then you have to go for specific cochlear tests like short increment sensitivity index, CC test, and ABLB, alternate binaural loudness balance test. And this is how you have to go. Patient had progressive conductive hearing loss without any significant cause. Well, progressive conductive hearing loss without any significant, I think otosclerosis is the pathophysiology. In case of a progressive conductive hearing loss without tympanic membrane perforation, you have to do a tympanotomy. You have to do a exploratory tympanotomy, which is called anterior tympanotomy, and then you have to find out what is the pathology inside. You can have otosclerosis, you can have tympanosclerosis. Uh, Only these two are coming to mind because you said progressive. If it's a congenital malleus fixation, it will not be progressive. There is no medical management. We have to go for a tympanotomy. Exploratory, okay, exploratory tympanotomy. Okay, so I think role of caraverin is not yet very scientifically proven. There are some reports which is mostly in animal models. It is see the treatment of tinnitus should be finding out the cause of tinnitus, and if there is a specific cause of the tinnitus, you have to treat that cause. If you can't find the cause of the tinnitus, you have to go for different tinnitus retraining therapy or cognitive behavioral therapy, because no medicines, caraverin, vitamin B12, and beta histine, and ginkgo biloba. So many medicines have been tried, uh, but there is lack of clarity on whether they are actually helping the patient or not. I think there are no new questions. Okay, so thank you so much for the class. Is the host here? Hello? Is the host of this meeting here?
Yes, sir. Yes, sir.
Yes, sir. So can I leave or?
Yes, sir. Thank you very much, trainees and faculty members for joining.
Okay, okay.